Radomski, Chapter 21, Optimizing Motor Planning and Performance in Clients with Neurological Disorders. We are going to begin with the motor impairments typical for acquired brain injury. We have a primary motor impairment, secondary motor impairments, and adaptive features. Our primary motor impairments are deficits that are directly attributable to the brain lesion. They come in positive and negative forms, positive including spasticity, abnormal reflex activity, ataxia, intention tremors, and resting tremor. Negative including paralysis, sensory loss, fatigue, etc. Secondary motor impairments are preventable deficits that develop over time in response to immobility, inactivity, or asymmetries in postural alignment, examples being limited range of motion, pain, and edema. Adaptive features are disorders of movement that develop in response to a person's attempts to move within the constraints of limited mobility, specific weakness, hypertonicity, and muscles. For the theoretical paradigms that have guided rehabilitation interventions over time, these are the theoretical paradigms that have guided intervention for people with the brain injuries, starting with Brunstrom's movement therapy in 1951, treatment of approach designed to facilitate the progression of stroke survivors through the stages of recovery. Three major contributions from this theory are the detailed descriptions of reflexes and reactions displayed by patients with post-stroke hemiplegia, concept of flexor-extensor synergy patterns in the paretic limbs, created a sequence of treatment allowing patients to move through 7 stages of recovery. This theory also produced the Fugl-Meyer motor assessments. This is a widely used adaptation of the Brunstrom's hemiplegia classification and progress record. Here's a picture of the stages of stroke recovery according to Brunstrom. Our next theoretical paradigm is Rude and Pianet. They believe that motor recovery followed a hierarchical sequence and advocated that patients reutilize the movement sequence displayed by typically developing infants during the first year of life. So this hierarchical concept is that stroke survivors recovered motor function in a proximal to distal sequence. Specific sensory stimuli utilized for facilitation or inhibition of motor firing within selected muscles, so that included reciprocal inhibition, which is stimulation to a muscle will simultaneously elicit inhibitory neural signals to its antagonist and relax the spastic muscles. The modern approach do not use the facilitation or inhibition techniques of Rude, Pianet, but instead have adapted the ideologies to new practices, including Botox injections, GABAergic medicine. The functional electric stimulation replaced the facilitation techniques, and kinematic and kinetic linkages support the use of diagonal patterns of lip movement in therapy instead. Finally, we have NDT, or the Bobath approach, viewed hypertonicity as an obstacle to a person's ability to move freely. Abnormal movement patterns post-stroke are difficult to break and are not functional long-term. They conceptualized that the underlying cause for limb synergies were secondary maladaptive strategies, or adaptive features. Introduced the idea that therapy could prevent the development of abnormal limb synergy patterns by removing mechanical obstacles to movement. Finally, we have the interventions designed to develop effective movement strategies. These systems include the dynamic systems, ecologic systems, and motor program theory. In dynamic systems, we have a nonlinear system that provides a mathematical paradigm for conceptualizing phenomena that are subject to unpredictable changes over time. So this intervention believed that it was self-organizing, or that they would continue to seek solutions for problems that may arise from internal or external challenges. And then it was believed to be heterarchical instead of hierarchical, meaning the motor control is dispersed in neuron site, internal and external to the CNS. Efficient solutions are those with the fewest degrees of freedom. And they believe that the system would naturally seek out those most efficient solutions. And ecological systems explores how multiple factors interact to influence child development. And motor program theory is a memory-based schema that controls coordinated movements. So in a generated motor program, pre-structured sets of central commands that govern a particular section of movement actions. These actions had attractors or attractor sites, which is a preferred pattern within a motor control system that develops a consistent pattern of performance. The goal of this intervention is to develop flexible motor programs for performing motor sequences that serve as the basis for functional movements. In these flexible motor programs, there are going to be constraints and affordances. Constraints include factors that limit the choices that are available, whereas affordances are factors that invite particular choices. over here, we are going to continue to the constraint-induced movement theory, or modified constraint-induced movement, and learn non-use. In CIMT, applicable to only stroke survivors who have a high level of motor ability. So the protocol had 90% of the time they were wearing a handband that constrained their movement of the unaffected side for 2 weeks, and practice sessions for 6 hours each weekday, Monday through Friday. It has shown over time and under studies that positive change in neural organization after completing the 2 weeks of CIMT, whereas the modified CIMT created a response to the lack of clinical feasibility to complete the CIMT protocol, seeing as it was very strict and lasted only 2 weeks, and had a very limited amount of post-stroke survivors that were even considered candidates for the program. So this protocol, you would wear your constraint for 5 hours a day, for 5 days a week, for a total of 10 weeks. This would include practice sessions 3 days a week for only 30 minutes to 3 hours maximum, rather than the 6 hours of the traditional CIMT. Advantages to the original CIMT is that it would initiate movement more quickly, perform tasks with straighter and smoother reaching trajectory, improved movement speed and coordination, improved efficiency of movement in the temporal and spatial, and increased shoulder flexion during reach. And now we have the effect of CIMT on stroke rehabilitation as a whole. DSC to neuro rehab therapists provide an external challenge during task-related practices to foster an environment that encourages the patients to properly utilize their affected limb. Success of CIMT is attributable to the wide opportunities the intervention provides for varied, intense practice that is motivational to the patient. Patient accountability and responsibility is vital to the success of CIMT. It works most efficiently with patients that are most motivated to engage in that 3 hours or 6 hours of intense sessions. And now it is debated versus unilateral or bilateral movement. Bilateral arm training is the therapeutic technique in which patients perform repetitive, identical movements with both arms simultaneously. More stroke survivors can participate in this activity, seeing as there are less strict rules for candidacy, and therapeutic influence on improving proximal arm control, as well as more cost-effective than the complete CIMT in the unilateral approach. Robotics and virtual technology can also be used in CIMT and stroke rehabilitation, and it supports several of the principles that CIMT enforces.